Hello, I'm Roger Luckman from UMass Medical School, Department of Family Medicine and Community Health. Today, in part one of this module, I'm going to be talking to you about recommendations and information for patients who are at increased risk for cancer. I'm going to be focusing on some basic principles that can be applied to a number of different cancers. I have nothing to disclose. So, the effect of higher cancer risk on screening performance and outcomes can be described and leads to a couple of different possible outcomes. So here are some of the potential implications. If the cancer-specific mortality in a population is increased, there's actually the potential for a greater reduction in the absolute mortality for those who are screened. So it's simply that folks who have more likelihood of dying from a cancer, if the screening test is going to work, they actually will have an absolute greater benefit than the average risk person. We'll talk more about how we get to that conclusion a little bit later. Another piece of good news for people who are at high risk is that the probability of false positive tests in screening is going to be somewhat lower, and that's just a product of the mathematics. It's not as if they don't have a higher risk or a higher risk of a positive test, but the false positives are somewhat lower. For some folks, the age to start screening might be a little bit younger than in an average risk population. If the incidence of the cancer begins to rise at an earlier age, then starting at a younger age may make sense. Finally, if we find that the mortality from a cancer is substantially greater than you'd expect from the incidence, that could suggest we're dealing with an aggressive cancer and a shorter screening interval might be indicated. So I've divided increased cancer risk into three basic types. And for the first type, we have type 1A and B. What you can see from this slide is that for type 1A, incidence and mortality are proportionally increased. They're increased about by the same amount. This suggests that the increase in mortality for folks who have this risk can be said to be due entirely to the increased incidence. They just have more cancer, they're going to die or get serious disease at the same rate, so of course that's going to be somewhat higher, and it can be entirely explained by the increased incidence. And a good example of this would be white women with breast cancer who might have risk factors of a young age at menarche, a higher age at first live birth, or a family history, for example. So type B here, you'll see also has the two blue arrows, pretty much the same, showing a proportional increase in mortality with an increase in incidence. Now you'll notice here that I have as the comparison population a high-risk screen-eligible population. Whenever we talk about increased risk, we're talking about a comparison of some kind, increased over what? For this type 1A I talked about here, the increase is over the general population of women the same age as the high-risk woman. So it's a general population comparison. But when we're talking about lung cancer in this type 1B, we're talking about the population that's eligible for lung cancer screening, which is already at high risk, and we're talking about folks who may have risk factors like a much greater total smoking exposure or family history that puts them at a risk even higher than all those folks who are all eligible for lung cancer screening. Now down in type 2, we see that the increase in mortality is proportionally greater than the increase in incidence. Prostate cancer is an example of this, and it's suggestive that it suggests that incidence alone is not the only explanatory factor for the higher mortality. We need to look a little bit further for other possible issues, risk factors, or potentially some things to do with access to treatment. The key here is that we can't be 100% sure the screening test is going to work exactly the same way because we may be dealing with, at least in some men, a type of cancer that may be more aggressive, may need to be detected even earlier than your average cancer. Now, in type 3, we have an unusual situation where, in fact, the incidence in the high-risk group maybe actually decreased compared to the general population, or it may be about the same. And yet, the mortality is substantially increased. So as with prostate cancer, this suggests that there's something going on with mortality that is not entirely explained by incidence, since there is no increase in incidence. And again, we may have to look at other risk factors or possibly access to care as being a critical issue. So let's start by delving a little bit deeper into this type 1A, looking at breast cancer in white women. We have here a patient, a white woman with increased risk of breast cancer. And as we'd expect, probably an increase in breast cancer mortality as well. She's age 40, first menstrual period age 13, first live birth age 28, and no known BRCA mutation. No history of a breast biopsy, and her mother diagnosed with breast cancer at age 50 when she was postmenopausal. So family history being the major risk factor here. Now, for those of you who went through the second module, this may look somewhat familiar, a recommended approach to assessing the risk of women for breast cancer. And you can see here that we have identified in the first box that there is one first-degree relative with breast cancer. And because we said yes, we're supposed to access a risk assessment tool. Now, there's one listed here, the FHS-7. I happen to, for this particular patient, choose another tool called the Ontario Family History Assessment Tool. This assigns points to family history of breast, ovarian, colon, and prostate cancer. And there's an increased weight in those points to first-degree relatives and younger age at onset. If you get greater than 10 points, they recommend a referral to a genetic counseling and possible BRCA gene testing. So running our patient's history through this tool, we find that the total score is 4. So therefore, we don't have to refer for genetic counseling. And our next step here, as in our algorithm, is to estimate the patient's lifetime risk. To do that, we're going to go to the Breast Cancer Risk Assessment Tool that's available on the National Cancer Institute website. And you can see here that we have basically entered this patient's medical history relevant to breast cancer into the tool, her age currently, her age at menarche, age at first birth. And we have one first-degree relative here that you can see who had breast cancer. And we have a race down here. And with a simple click, we get these estimates from that breast cancer risk assessment tool. 5-year risk of this patient for developing breast cancer, about 1.1%, compared to the average woman age 40, 0.6%. Lifetime risk, about 18.8%, compared to the average woman's lifetime risk of 12.4%. So the ratio of this patient's risk to the average patient's lifetime risk is about 1.5. Now, given that we think mortality and incidence are going to be increased proportionally, we can assume that the relative risk for both incidence and mortality is about 1.5. So for this patient, starting at age 40, the average 10-year breast cancer mortality would be about 6.7 per 1,000. And that would actually be the average risk. The high-risk patient is on the next line down as 10.0 per 1,000. So that's 1.5 times 6.7 is 10, basically. We're going to assume that the relative mortality reduction of screening applies in this case. And so the breast cancer deaths averted over 10 years of screening for the average woman, we know, is about 1 in 1,000 screened every other year. For this woman, it would be about 1.5 per 1,000 because she's 1.5 times the average risk. So the benefit is a little bit greater. So what about the false positive rate? We've mentioned that that's potentially lower in these patients at higher risk, and simply because it's inversely proportional to the probability of cancer. When the probability or the prevalence is higher, false positive rate is lower. And it's all the result of that pesky formula, Bayes' theorem, that we all learned in medical school, that relates sensitivity, specificity, and prevalence of disease in a tested population. So the test works better in people with higher prevalence. So what might you say to this patient? The probability of cancer death averted, if you accept screening, is about 1.5 in 1,000 over 10 years. And this is a little bit better than the average person, maybe not dramatically so, but it's a little bit better. And it may be for this person a reason to start screening before age 50 rather than waiting to age 50. And she may find that this is compelling. The probability of false positive tests, as we mentioned, also somewhat lower. The woman may decide, based on this information provided to them because she's at higher risk, that she has some greater benefit, less harm. Maybe it's a good thing for her to do. So let's move on and talk about this type 1B. Here we're going to look at lung cancer. And we have a key risk factor here, number of pack years of smoking. In this graph here, you'll notice that we have in blue the 60 pack year history risk of lung cancer mortality, and this is for age 50 to 59, and over here on the right side, age 60 to 69, and then you go all the way up until you get to the yellow, which is 160 pack years, and you see there's substantial increase as we increase in the number of pack years. It's a major risk factor within that group of already high-risk patients. So we have a patient at high risk for lung cancer, age 55. He's a male, pack year history of 80 years, smoking, has not yet quit, has no other exposures. And we're going to go into another screening decision tool, similar to what we saw for breast cancer at the NCI site. This one happens to be located at a Memorial Sloan Kettering Cancer Center site. And we're going to enter into this our patient's parameters, age 55, smoked 40 years, and smoked about 2 packs a day or 40 cigarettes, has not yet quit smoking. And we're going to get this output. What this tells us, and it tells us about risks over a period of 6 years. Why 6 years? The original trial that led to the approval of lung cancer screening, the NLST trial, had a follow-up of 6 years initially from the beginning, so it's using that particular interval. Down the road, we should have 10-year and other intervals available to us. So out of 1,000 people who are not screened, the risk over 6 years is 22 out of 1,000. Pretty high risk for death from lung cancer. It's almost 2.2%. And if you are screened, that drops to about 17.6 out of 1,000, leaving about 4.4 deaths from lung cancer averted by screening. And another way of looking at that, number needed to treat. If you screen 228 men like this, then 1 man is going to benefit by avoiding death from lung cancer. So what do we compare this to? Let's look at the minimum risk patient who might be still eligible for lung cancer screening, and that would be somebody age 55 who's a woman, pack year is 30, the minimum acceptable for enrollment in lung cancer screening. And she quit 14 years ago. If you quit 15 or more years ago, you're no longer eligible. She has no other exposures. So what would her death rate be over 6 years using the same tool? It would be 0.8 per 1,000 compared to 4.4 per 1,000. So that's more than 4 times greater benefit for our individual compared to the average patient. So what might our message be to this patient? So you're at very high risk for lung cancer and for dying from lung cancer. Your risk of dying in the next 6 years from lung cancer, if you don't get screened, is about 22 out of 1,000. If you do get screened, your risk can be reduced by about 20% to about 18 per 1,000. So again, the reduction of risk is still at 20%, same for both groups, but because the risk is higher, the 20% reduction yields a larger number of individuals who have the potential to benefit. And we might further tell that patient that out of 1,000 men like you were screened, about 4 men will benefit by avoiding death from lung cancer. And it's probably true if you continue screening beyond 6 years, the benefit will continue to increase every year. And because of this high risk, you might benefit more from folks who are at lower risk in lung cancer screening. That might be helpful for that patient to make a decision. Now we're going to skip over prostate cancer because my colleague is going to give you a lot of information about that in depth in just a few minutes, and move on to looking at breast cancer in women who are of African American descent, where we have this kind of unusual situation of a lower incidence and a higher mortality. From this table, you can see that the incidence for black women, 125.5 per 100,000, is less than that for white women at 128. It's about 97.5% of that incidence. But the mortality, on the other hand, things are reversed. mortality is 29.9 versus 20.8 among white women, and we have 1.42 times the mortality in black women. So our patient, again, let's say age 40, African American, age at menarche 13, age at first live birth 27, no family history BRCA, no biopsy. And we go again to our risk tool, and here we find lifetime risk for the patient we just talked about, 9.6%. For the average African American woman, 9.9%. For the average white woman, 12.2%. The 5-year risk, 0.6%, is more similar across the board because the risks are lower overall for all groups there. So how do we estimate the benefit from screening? Well, we can make an assumption, which may or may not be accurate in this case because mortality is so much higher than the increase in incidence, that it's possible the usual percentage decline in mortality from screening may apply. And if we do that, we would find that we would be multiplying our 1 in 1,000 benefit, typical for the average woman, the average white woman, by 1.4 because of the higher mortality. And we would say to this patient, maybe you have a little bit better chance of benefiting from screening. Maybe. But the benefit may be less because we don't know as much as we should about that reason that you have an increased mortality beyond that expected from your incidence. So we might say to this woman, screening is indicated, but may not reduce breast cancer mortality by the same percentage as for white women. We don't know that yet. We hope to learn sometime in the future. Possible risk factors for your increased risk could be something genetic or other factors that lead to more aggressive cancer. Or it could be that for women like yourself, access to and receipt of effective cancer care has been less. And finally, minimizing the interval between screens to about every 12 months might increase your mortality reduction because we think it's possible you have a more aggressive form of cancer. But evidence for this is somewhat limited, but it's a reasonable thing to consider. So in summary, estimating the risk of cancer incidence and mortality may help patients make more informed decisions about screening. Comparing a patient's risk with average risk or lower risk patients may help patients put their risk in perspective. Online risk calculators can be used for this, and they're available for breast and lung cancer, easily accessible. Knowledge of risk, in the end, may allow estimates of benefit, which may be greater for some patients when incidence and mortality are higher than average. Thank you for your attention.